He he loaded the dishwasher like a
What's in Latin? Read the slide.
Good evening, everyone. My name is Kelly Macauley, and I'll be your host for today's online office hours. To start, if you could just pop in the chat when you're sitting for the exam, that would be great. It's nice to just get an idea of when everyone is getting ready to take it. I think that's the biggest spread I've ever seen. Looks like we have some people who have it right around the corner, and then all the way out to some people who are very good planners who aren't taking it for a while. Good for you. So, what we're going to talk about today is focus mostly on the pulmonary system initially and talk about the processes behind gas exchange and how that impacts movement and what we can do as a physical therapist about that. And then we'll spend some time just going through some different types of practice questions across the entire cardiopulmonary spectrum. If you have any questions as we're going through, please don't hesitate to jump in and throw them in the chat or raise your hand or do something to get my attention. Otherwise, we will go ahead and get started. So just a little bit about me. I am currently a clinical professor and the director of curriculum at Northern Arizona University in the hybrid program. I actually live in Scarborough, Maine, so I'm a little far. I would do in for longest commute to work when I have to go out there, but I only end up going out probably once or twice this semester. My educational background, I have a BA where I majored in psychology with specialization or concentrations in math and developmental psychology. I have my DPT from MGH Institute of Health Professions, and then I have a doctorate of education from the University of Phoenix, which I specialize in educational leadership with a specialization in educational technology. I chose to do that because I have a very big interest in simulation and like to incorporate that into my teaching. I'm board certified, I'm emeritus now in both cardiovascular and pulmonary PT and geriatrics. So for those of you who are just starting your studying, you know that about 13% of the exam consists of cardiovascular and pulmonary content, which translates to about 22 to 27 questions. And you never know how many of those are actually going to be on the exam because it shifts every time. But the good news is the content that you have for this section is spread out pretty evenly between examination and sort of the evaluation and diagnosis and prognosis, and then interventions. So you'll sort of see a smattering of those across the exam. It does still leave a wide range of things for you to assess. So what are we going to talk about? So we're going to talk a little bit about gas exchange pathology and how you interpret different tests and measures that are associated with gas exchange impairments. And then we're going to, again, review some questions just across the spectrum, some cardiac questions, a couple of EKG interpretations, some intervention questions, just to give you some practice and a chance to ask some questions across the gamut. So when we're thinking about the pulmonary system, the good news is there's really only about 3 things as a physical therapist that we can, let me say, intervene on, I guess, or really assess. Unfortunately, a lot of times when there's damage to the pulmonary system, most of it's not reversible. However, there's ways that we can maximize a patient's function. So one of the ways that you can do that, or three of the different categorizations are here on the screen. The fourth one we're not going to talk about. It goes a lot further beyond entry level, and that's respiratory failure and the manage of failure and patients on vents and things like that. So that's not a huge component. It's really not on the boards at all. So that's not something you have to really worry about. These 3 things are a little bit more important. So when we're thinking about the first one, which is an airway clearance dysfunction, that's when a patient has usually some sort of secretions, mucus, things like that in their lungs. And it's usually from a pathology that is constant. And there's always this creation of secretions. So we have to manage that in some way. A couple of pathologies where that happens often is cystic fibrosis. Glad we're on we've got some great research that's actually helped us to getting closer and closer to actually eradicating that with, the different gene therapies. But it does still exist for a percentage of the population. Bronchiectasis is another one that where you have constant secretions, and chronic bronchitis. Those are probably the three most common chronic diseases that cause an airway clearance problem. An airway clearance is usually related to the other two problems that we have here. If you have a lot of secretions or mucus that are in your lungs, especially in your alveoli, it's gonna make it harder for gas to diffuse from your airways into the capillaries. So you end up with a gas exchange dysfunction, which we're gonna spend some time chatting about in a second. The other dysfunction that we frequently see as a physical therapist is a ventilatory pump dysfunction. And that is related to the concept of moving air in and out of the lungs. And when there's a dysfunction related to your ventilatory pump, it's usually characterized in two different places. One of them is your lungs itself. It's usually some sort of damage to your lungs that causes an inability for them to expand easily when the pressure changes within your thoracic cage. So in order to take a deep breath, you have a rapid shift in pressure that allows air to go in. If that shift in pressure can't occur, or for some reason the tissue is really stiff, then you end up with a ventilatory pump problem. The other component that is related to a ventilatory pump problem is actually your thoracic cage itself. You need your thoracic spine and ribs to be able to move. You need the motor function to be able to have your muscles be innervated so they can allow that to move. Your diaphragm obviously needs to be innervated and functioning. Those are all really important for helping to facilitate air movement in and out of the lungs. If you have different types of injuries, and the injuries could be so many that would impair your ventilatory pump, it could be any sort of neuromuscular disorder, something like a spinal cord injury, myasthenia gravis, Guillain-Barré, sometimes, depending upon the extent of it, ALS, all of those can cause a ventilatory pump dysfunction. You can have musculoskeletal issues that can cause ventilatory pump dysfunction. They can be more progressive or more permanent. Like think about something like an ankylosing spondylitis or something like that that's going to cause a really stiff spine and not allow you to expand and contract and take deep breaths. It's, a really severe kyphosis, or it could be something transient. You get a couple of rib fractures. If anyone's ever had some rib fractures, then you know that it makes it really hard to take a deep breath. Or if you guys have seen patients with rib fractures, they're really rough and they really impact your ventilatory pump. It could also be other secondary systems that can impact your pump. Think about connective tissue disorders. So someone with something like scleroderma or lupus, where you may have decreased elastic properties within your tissue, so it can't expand as it normally would. It becomes really, really stiff. So in order for your ventilatory pump to work, it has to be actually extremely strong to overcome those forces, and ultimately it usually can't. Those are more progressive disorders. It could be something transient. Again, think about something like a burn. If you have someone who has a burn across their thorax, it's going to make it really tough for you to expand. So all of those can cause ventilatory pump dysfunction. If the ventilatory pump dysfunction is severe enough, it can lead to decreased air moving in and out. It won't change things at the gas exchange level necessarily, unless it's depending upon the injury, but it's just will decrease the amount of air that can move in and out. It's possible that gas exchange can remain intact in those conditions if there is no pathology at that level. A lot of times we see concomitant pathology, so we see these three pulmonary issues usually happen at the same time. Let's delve a little bit more into the gas exchange. Oops. All right, so the nice thing about it is that there really are only 3 tests that we need to worry about when we're considering assessing for a gas exchange problem. And the reality is we usually only have one that's accessible to us easily. And that is measuring someone's SpO2. When you're measuring someone's SpO2, the absolute normal value for SpO2 is somewhere between 98 to 100%, depending upon age. The reality is it doesn't get like normal for someone who's normal and has an SpO2 of 98 is usually someone who literally is in their late 80s or 90s. Below that, your SpO2 really, if someone should be around 90 to 100%. Don't take that to mean that you should call an ambulance if you have a patient who has an SpO2 of 95%. How I want you to conceptualize that is it's a little bit lower than normal, but it may be completely fine for that patient. And it may just be that, the person's just not taking a deep breath, or maybe they have a little bit of an upper respiratory infection. Maybe you already know that they have a pathology like COPD or pulmonary fibrosis that's leading to some sort of gas exchange problem. So we always have to put this in context. So I always encourage my students to think about it in, okay, this is what normal is, and this is what the patient is. Okay, I know it's either normal or abnormal, but if it's abnormal, how much do I really care about it for this particular patient? Or in other words, what am I going to potentially do, or do I need to intervene? And that really becomes an it depends answer, depending upon the patient in front of you and what their history is and things like that. But again, measuring the SpO2 is really the most accessible way that we have as PTs to determine if someone has adequate gas exchange. The gas exchange is only, SpO2 only measures oxygenation, but for the most part, that's really all we care about for most patients. We do have the ability to interpret a PaO2, which is the partial, pressure of oxygen within the arteries. Or a PaCO2, which is the partial pressure of carbon dioxide in the artery. So that gives us a little bit more picture truly about gas exchange because we're getting data from both oxygen and carbon dioxide. The reason I say that this is a little bit less accessible for us is because the way we get this information is from an arterial blood draw. So that means there has to be a blood draw from an artery. Remember, most blood draws that we see or you see in the hospital, or most likely when you've had blood drawn, if you've ever had that, if you've been at the hospital, at your PCP's office or something like that, that's a venous draw, which is different from this. This literally is a draw that comes from the artery, and it requires either a physician NP or a PA to do that. So it's not something that we're doing in the clinic very often. I've done a lot of my clinical care in the ICU, so I've had the ability to get that information pretty routinely, especially if someone has an arterial line where they can just take the blood right out of there and they don't have to do a stick. But the risk for getting this assessment is a lot higher than it would be for a venous draw. However, it does really give us an idea of what their oxygenation level is within their vascular system. All that being said, the normal PaO2 for oxygen is around 100. Sometimes you'll see a range from 80 to 100 millimeters of mercury, and that's completely fine to consider normal. But really, it should be around 100 given no pathology. Normal partial pressure of CO2, either at rest or with activity, is right around 40 millimeters of mercury. Again, you may have seen a range for this between 35 and 45 millimeters of mercury. That's completely fine to consider, whichever way is easiest for you to remember. So those are the normal values that we have. And again, those are the only tests and measures as a physical therapist that are really relevant to us as we're thinking about this conceptually of gas exchange. Let's talk a little bit more about what we mean when we're talking about gas exchange. So we have a picture here of the pulmonary system really blown up. So what you can see here are we're getting down to the bronchi and really down to the terminal respiratory units here. And you can see that down at the bottom here, we sort of have those little balls, which are the alveoli. And surrounding the alveoli, you have this anastomosis and matrix of the vascular system. And what happens in the pulmonary vascular system is the arterial system joins right with the venous system. And that's what you can see here. And it creates sort of an anastomosis. And where they connect is, it's not like a tube as you think of like with a blood vessel. I always think of it almost like a bog where the vessels meet. It's so you can't, so, and another way to think about that, if I have a clot in my arterial system, or my either one, in your venous system or your arterial system, it can't pass from one system to the other in these capillary beds, because you don't have a passageway for it to pass through. It ends up sort of in this this place where you just have the information in there. I mean, not information, the blood in there. So what we're looking at when we're thinking about gas exchange is we have air coming in through, obviously you breathe it in through your mouth and your nose, and it gets into the airways. And it gets all the way down to these terminal respiratory units. And once it gets into the alveoli, the gas then diffuses across the membrane into these through into the capillaries, and then it's transferred out throughout the body. We're going to circle back to that in a second, and I'll give you a little bit more specific information, but this gives you a little bit of a step back view of that. One thing I wanted to talk about before I went any deeper there is just thinking about the concept of dead space, which will help you to understand the next piece. So dead space is area in your lungs where gas exchange can't occur. And you can have two types of dead space. The first part is anatomical dead space. So when you breathe in, your air travels down through your trachea to your bronchioles, all the way out to those terminal respiratory units, and that's where we find the alveoli and the alveolar ducts. If you're up here in the upper part of your respiratory system, in your trachea, your mainstem bronchi, and even in some of those bronchioles, there is no place, excuse me, oxygen gets lost in there, essentially. It's like it doesn't, like there's some percentage of the oxygen that you breathe in doesn't travel all the way down to these terminal respiratory units where gas exchange can occur. And that will affect your pressure of oxygen within your system, because it gets lost in these dead space areas. So, and again, everybody has dead space, anatomic dead space, because everyone has a trachea, their bronchioles, where gas exchange can occur. There is something called physiologic dead space, which is an area that's ventilated, which means we can get air down there, but it's not perfused. So you can't have, you don't have gas exchange occurring because there's no blood flow getting there. And so we're talking about areas down here in those alveolar ducts. And the primary reason why you have physiologic dead space is from like a pulmonary embolism. So it goes in, it clogs off the blood flow distal to where the embolism is. So that area that's distal, even though air can get down and there may be oxygen sitting in the alveoli related to that area, gas exchange can't occur because the blood flow is not getting there to allow that diffusion. So let's look at that concept or that process of gas exchange. So this is obviously not quite anatomically correct picture, but it helps to give you an idea of the concepts that we were just talking about. So let's look up here. So we breathe in air. Generally speaking, the pressure of air in the atmosphere is about 159 millimeters of mercury, give or take. Obviously, it depends where you are and what the elevation is and things like that. But generally speaking, this is what the air is generally considered. By the time you have the air from the atmosphere into your trachea, we've already lost about 10 millimeters of pressure. It gets stuck in your mouth. It doesn't travel all the way down. So in your trachea, you have about 149 millimeters, give or take. Like, you don't need to memorize the numbers, but conceptually, I just want you to think about this process. By the time we get all the way down to your alveolus, we're down to about 100 millimeters of mercury pressure of oxygen. So between the ambient air outside and by the time we get all the way down to your alveoli, we've lost about 59, 60 millimeters of mercury pressure of oxygen. And what we're talking about, again, is the traveling from up here, from it coming into your mouth and going through all of these little bronchioles. So as it passes down through that whole process, oxygen is just getting stuck up there and not traveling down. So we end up in the alveolus with about 100 millimeters of mercury of pressure of oxygen. The alveolus, as you saw in that other picture, is wrapped by the capillary system. So what ends up happening is, because the circulating blood back, which is here in purple, that's being returned from the periphery centrally, the partial pressure of oxygen in venous blood is only about 40 millimeters of mercury. So that's a difference from the alveolus is about 100 to the venous blood is about 40. So that's a difference of about 60 millimeters of mercury. So what happens as the blood passes by this alveolus in those little capillary beds is the oxygen diffuses from the alveolus into the capillary. And then because of that pressure gradient, the pressure is so much higher in the alveolus, it comes down, or it diffuses across the membrane. Oxygen does a lot better. The higher the pressure gradient, it'll diffuse. It requires a higher pressure gradient to diffuse across the membrane. So then that pressure of oxygen is now in your capillary beds, and that's what that normal pressure of oxygen that we talked about before is, and that goes circulating throughout the body in the arterial blood, and it goes to the periphery to where we need it. Thinking of us as physical therapists, a lot of times our patients, because we're asking them to increase their activity and their function, we need the oxygen to get to their muscles so that they can perform any sort of activity. And so then the oxygen then diffuses into the different tissues where it's required. And then we're left with, in the venous blood, only about that 40 millimeters of mercury again, and that process continues. So again, it's key here that the differentiation is between the alveolus and the PaO2 is higher, so that there's an increased pressure because the oxygen is going to move from an area of higher pressure to lower pressure. If there's a pathology that's going to limit the ability for oxygen to get down here, then sometimes we need to actually increase the amount of oxygen so we can maintain that higher pressure so this diffusion process can easily occur. And that's a lot of times why we have to put patients on oxygen. And there's so many different reasons why that could occur. I mentioned one before. If there's a lot of secretions in the airway, it's going to make it harder for that oxygen to get all the way down to the alveolus. So it may leave the partial pressure of oxygen there only about 80, and even then that would still come across, that really wouldn't cause a problem. But if it gets down to about 60, then it's going to be a lot harder for that oxygen to diffuse. Another pathology where it can cause the diffusion of oxygen from the alveolus to the capillary, to make that a little bit harder, is something like pulmonary fibrosis. And the reason is because you have a thickening of the lung tissue right here, sort of in this area between the alveolus and the capillary. So it makes an increased thickness for the oxygen to have to diffuse from the alveolus to the capillary. That can, in some patients, it's not a problem at rest. And if you've seen a patient with pulmonary fibrosis, it may be, depending upon the progression of their disease, they may be okay at rest. Where it really becomes a problem is when they exercise and the rate of the circulating blood throughout the system is a lot faster. And so it takes longer for the oxygen to diffuse from the alveolus to the capillary. But if the blood's circulating faster, because they're working hard, their heart rate's up, it doesn't have time to diffuse. And that's when we see patients with pulmonary fibrosis start to decompensate and desaturate because they're not able to keep up with the demand. At rest, it's okay, but when they exercise, they can't keep up with the demand because of this. It takes longer for the oxygen to diffuse. And honestly, when I'm talking about longer, we're probably talking like milliseconds longer, but physiologically that has a huge impact on the patient's ability to function. So that's a patient who frequently with activity will require supplemental oxygen so that we can increase the pressure here. Because again, the more of a gradient we have between the pressure of oxygen in the alveolus compared to the capillaries, the easier it's going to diffuse across. So that's a great example of when we may need to give someone oxygen with activity in order to mediate that problem. The other piece that's on this picture is the partial pressure of CO2. So the partial pressure of CO2 in the ambient air is very low. As you can see, it's less than 1 millimeter of mercury. And that pretty much stays that way all the way through. You don't lose a ton of it. And it's so low anyway that it doesn't really matter, but you don't really lose a ton of it to any sort of dead space and things like that. And when you get to the alveolus, it's a little bit higher because what happens is in the circulating blood as waste product, your pressure of CO2 is about 46 millimeters mercury, give or take. And then because the pressure is lower within the alveolus, it diffuses in there. And then it takes, and some of this is expelled, and depending upon the person's function and pathology, as they breathe out, they're going to get rid of that extra CO2. The thing about CO2 is it does not require as much of a pressure gradient as oxygen. So what I'm saying here is that in the venous blood that the pressure of CO2 is about 46, and it easily transfers into the alveolus when there's only a 6 millimeter difference. Not 6 millimeters, 6 millimeters of mercury of pressure difference between the two spaces. Whereas I was saying before with oxygen, we function best if we have a difference of a pressure gradient of about 60 difference. So it's a lot easier for CO2 to diffuse than it is for oxygen, is the short piece. So we oftentimes don't have trouble with that process or that getting oxygen from carbon dioxide from the arterial blood to the alveolus. Something that has even a higher ability to diffuse and also bind with hemoglobin over oxygen is carbon monoxide. That's why people are very susceptible to carbon monoxide poisoning. If they're exposed in a fire or something like that, because it can diffuse very easily across this membrane, and then it has a very high affinity to be able to bind with hemoglobin, so it displaces oxygen. So people become hypoxic when they're exposed to that. All right, that's enough of this picture. Let's take a look at the oxyhemoglobin curve. So I don't want to get too bogged down into the specifics on this. However, the one thing I want to talk about is the relationship between SpO2, which is what we're measuring, the percentage of oxygen that's bound to hemoglobin, which is what we're measuring when we're using an oximeter, a pulse ox. And how does that compare to the pressure of oxygen in the blood, the partial pressure of oxygen in the blood? So let's look at this picture on the left first. They're both showing the same thing. But on this picture on the left, you can see that if we're looking at, let me say one other thing before I delve into the picture. But the reason this is important is what I said at the beginning. We almost always have access to a pulse oximeter. Our ability to get a real partial pressure of oxygen is pretty limited. So it's helpful to be able to think about how can I translate the number that I'm getting in a pulse oximeter to the partial pressure of oxygen, so you can understand physiologically what's happening to the patient, because that may dictate what you're asking the patient to do and how much you feel like they can respond to you, whatever you're asking them to do from a movement or exercise perspective. Okay, that being said, if you look at your SpO2 up here, it's 100 corresponds to about a partial pressure of oxygen of 100. And we said that was pretty normal. One of the important things to note is the shape of this curve. Up here, it's fairly flat compared to here, we're on a downhill ski slope. It's really steep. And that's important to remember because it takes, if you look at the difference between 190 here, it's not a big difference on the partial pressure of oxygen. We have dropped down to 60, but we have a lot of leeway here. And that's why I was saying earlier, yeah, the normal SpO2 is somewhere between 98 to 100, which stays right up at the top of this curve. But even if you go down to 80, you're still doing just fine. And that probably corresponds to a SpO2 of 95 or 96. So you have a lot to play with there before you start to see a change in the partial pressure of oxygen. This is a really key point. When you get to an SpO2 of 90%, you're at about 60%, a partial pressure of oxygen of about 60. And the reason this is a key point is because this is where the slope of the line becomes much more steep. And what that means is it's the point at which it's going to become much harder for oxygen diffuse from that alveoli through the capillaries. And then again, the pressure in the arterial system is going to be low, so it's going to make it harder to get that oxygen to the periphery, to the tissues that need it. So this is when you have to start to get nervous when you're treating a patient. And you really need to think about what you're doing with that patient, because they can decompensate really quickly here. And let me say that one more time. So up here with an SpO2 of 90 to 100, you have a lot of room here where the patient probably is going to be just fine, and you can push them a little bit, and they'll probably recover, because until you get to this point, there's still an adequate differential between the partial pressure of oxygen in your alveolus and your capillaries that you're going to have adequate diffusion. It's at this point when you have an SpO2 of 90, which corresponds to a PaO2 of 60, that you could potentially start to get into trouble if you really keep increasing the activity for the person, and they can desaturate and not have, which translates to not having a high enough partial pressure of oxygen, which means they're not going to be able to get enough oxygen to the tissues. That pressure gradient is not going to be adequate enough for that diffusion process to occur. Hopefully that makes sense. And this can happen really quickly here. Again, because of the way of the relationship between the two, with the relationship with the curve. Just a couple other key points to think about. As I said, 100 corresponds to about 100, but an SpO2 of 90 corresponds to about a PaO2 of 60. An SpO2 of 80 corresponds to about a PaO2 of 45-ish, give or take. And then if we have an SpO2 of 50, I mean, the PaO2 is terrible. So this person's not even going to have the ability to have gas exchange occur. And they're really, even here, an SpO2 of 80, it's going to be very difficult for that person to have a pressure gradient adequate enough between their alveolus and their capillaries to have gas diffuse from one to the other. So if you're thinking about it functionally, this is where you really want to start to think clinically and sort of put in the back of your head that, this is a person that either the easiest solution is actually to have them have supplemental oxygen, so we get them back up here and they can tolerate activity. And this is actually the reason that in most places, to have oxygen covered by insurance is usually that they need to have an SpO2 around 88 to 90%, because physiologically, that's when the patient's really at risk. So that's where that number sort of comes from. So that's the other key point, that most patients, around that, they say, usually Medicare says 88, and then, as you know, most insurances follow that. So if someone has an SpO2 at 88, they can usually get oxygen covered, and that will help increase that pressure gradient, and boom, now they have the ability to exercise. This graph is really just showing the same thing here. And again, it's saying we have a while here. This curve is pretty flat here. So it takes a while for us to get here, but once we get here, boom, down the ski slope. And that person can decompensate. This is a handy dandy way to actually remember this. If you just take a piece of paper and you do 100, 90, 80, and then under it put 70, 60, 50, it helps you to remember this is what the SpO2 is and this is what the PaO2 is, that corresponds to it, so that you can remember here is where we're getting to that point where we're dangerous. But if you're down here, you really are creating a situation where that person is going to have a lot of difficulty with that gas exchange. And they're going to end up probably not being able to tolerate activity very well. This is another way to calculate it. If you like math, this might be for you. I like the one on the previous slide because it really is SpO2 and oxygenation for dummies, which I relate to really well. But this is if you like math, and I did disclose to you that I was a math major, but this one's a lot more complicated, especially if I'm treating patients and trying to think on my feet. But it gives you a little bit, it's probably a little bit more accurate than the one I gave you before. But again, the one before just gives you a ballpark of, hey, this is a little bit of a red flag. One last piece I want to cover before we switch into doing some questions is talking about the drive for ventilation. One of the key pieces to remember is that your levels of CO2 for most patients drive your ventilation. So, and we can see that in this graph here. You can see how much, so the minute ventilation is how many liters per minute volume that you breathe in 1 minute. And you can look how steep this line is. So if you look at this change between 30 and 40 millimeters of mercury here, you see a really steep change. So this tells us how sensitive it is. If I have a PCO2 of 40, how high my minute ventilation is compared to if it's only 30 and how low that is. So you can tell that it's really sensitive. And even a slight change in your PCO2 has a real effect on how much you're breathing. So again, that underscores the point that CO2 drives your breathing. Let's compare that to a picture of PO2. Look how much more flat this is. And a lot of people assume if someone's short of breath, they don't have enough oxygen, and that's actually really not the case. So if we look at the x-axis here, this is like your arterial PO2 is 120, and we talked about how it's actually normal would be 100. So to get to 120, you would have to probably have supplemental oxygen or something to that effect. But look how before we actually see the same response that we see here, your PO2, it's at that critical point that I was telling you about. It has to be about 60, and it's probably even a little bit less before you see oxygen actually impact your ventilation. So for most people, because they live in this area here above 60, your oxygen level is not going to impact your ventilation at all. So someone who's short of breath is not going to be impacted by that. It's not it. If you have people who are down here, it certainly will impact it. And that can certainly happen with certain pathologies. Or, it could be an acute pathology, or it could be somebody who has a chronic pathology. So the key takeaway point here is that CO2 really is quite sensitive to your drive for breathing, whereas PO2, your pressure of oxygen has to be quite low before it actually impacts your breathing. All right. So we're going to jump into a couple of questions here. Let me get my poll back up. Where did it go? All right, let me relaunch this. Hopefully y'all can see that. All right, 5 more seconds. I think we have everyone. So we have quite a choice here. And it's actually interesting as you guys were answering, I was thinking, the definition of critical point here is probably where we have a little bit of contention. What I intended for that was that point where you really need to think about what you're doing and what you're asking the patient to do. And that's where we have the beginning of that curve. And that's at that point, at that 90%, when your SpO2 is 90%, which corresponds to about that PO2 of 60 millimeters of mercury, that's that critical point where you need to start thinking about what your decisions are and what you're asking that patient to do. So that was my intention there. I'm guessing a couple of you probably thought, well, gosh, if it's down here, that's pretty critical too. Because this is where they're getting worse and the person's probably decompensating and not doing quite well. So I can understand potentially the way the questions were where you might have chose that. What I want you to remember is B being that point where we really need to think about what we're doing with that patient. And if they continue to desaturate, they can decompensate quite quickly. All right, let's try another one. Yeah, I think Janice Kim, I think that's a very fair interpretation of the question. And so if someone is that low, that would be the point where you would be very concerned about that patient. And perhaps, and I've used this question several times before, and I've never had people interpret it that way, but I could tell that's how you guys interpret it by the way you answered. So if we're thinking from a critical illness perspective, you're exactly right. As I said, what I meant by critical is really the point at which you should start to really reflect on we're starting to enter the next level of the patient's safety. All right. Looks like, oh, we still got some more people. All right, looks like most people under there. So we have really interesting here. Half people picked A, a chunk picked B, and then a couple of people picked C. So let's talk through these. I love this question because part of it is it causes you to understand oxygenation and the different delivery types for oxygen. So I'm going to talk about B first. So automatically you might assume, so they were put on 5 liters. And so I would say that people who chose B are like, I don't love that they only went from, they started at 48 millimeters of mercury up to 66 millimeters. And I'm sensing the people who chose B were like, I don't love that. We put them on 5 liters. I don't think that's enough. So I need to increase that. The issue here is that it says low flow nasal cannula, and a low flow nasal cannula really isn't effective above 6 liters. You can certainly use high flow oxygen above that. So that would be a key piece for B, and why B is not the best answer because it's not, you don't really, it only can really accommodate up to 6 liters of oxygen. So that makes that wrong. Your gut, though, in reading that and saying, this isn't great, I need to increase it, is good. So you're on the right track. It's just this piece makes it a little bit tricky. We have the folks here who picked A. The patient demonstrates normal oxygenation on the nasal cannula. So with a PaO2 of 66, your oxygenation is still not normal because you're probably around 90 to 92% SpO2. And like we said when we started, an SpO2 and normal SpO2 is 98 to 100. So this is still abnormal. This is still low. The question could be, if we had more context about this patient, back to one of my original points, it may be that we shouldn't have we would have to have a little bit more context about what the patient is, about whether we're going to do an intervention or not. C is a face mask, and if it's delivering 60% FiO2, it's automatically going to be above 5 liters per minute. And that gives this patient more oxygen, which will help them to give a PaO2 above 66% or 66 millimeters of mercury. So increasing the FiO2 is the best choice for this patient. Yeah, and that's where if you go back to that trick I showed you before, with 100 to 90 to 80, and then 70 to 60 to 50, that's an easy way to sort of help you convert that, and to give you a ballpark. It's not an exact science, but it does give you a ballpark. It's not, the measurement is a point in time, so it's not a trend. They move from one to the other, but then it's a new data point. So if it's staying there, then it's still too low to be there. It's a good thought if they hadn't stabilized there. All right, I think we've got most people here. So we have most people choosing C, decrease SpO2, and then we have some people choosing B and A. So C is definitely the correct answer, and we talked a little bit about the physiology about that before. This person potentially could have clubbing. And I intentionally put that choice in there so we could have this discussion. So the one thing you need to remember about clubbing, so clubbing's that change in the nail bed, and clubbing can be associated with chronic hypoxemia. So if you have somebody who has pulmonary fibrosis, who has been chronically hypoxemic, this absolutely could be the case. And on the boards, you wouldn't have an option where you would have both of these as answer choices. The reason that this would not be correct is it's not common to have asymmetric movement with pulmonary fibrosis. It usually happens bilaterally. It does depend upon the etiology of the pulmonary fibrosis. So for example, if you had localized radiation to one side of your lung or something like that, it could be unilateral. So that potentially is a very slim chance that would happen, but most of the time, it's the most common type of pulmonary fibrosis is idiopathic pulmonary fibrosis, and that would be more of a symmetric presentation. And we talked about earlier how pulmonary fibrosis leads to an increase, a stiffness within the pulmonary, the parenchyma of the lungs. So that's going to decrease the amount of expansion you have. So you're not going to have an increased expansion. All right. Let's maybe try one more here. All right. It looks like most people have answered. So most people said D. So let's talk through all of these. So blood pressure that stays the same with an increased workload is abnormal. That is correct. If you're increasing the workload and your blood pressure is not responding, then that is not a normal response to activity. Of course, it depends a little bit about the individual patient and how much it'll increase and what their fitness level is and how that works. But it should get to the point if we're starting to increase to a workload greater than rest for that patient, you should see an increase in their blood pressure, their systolic blood pressure. Diastolic blood pressure can go up, it can go down 10 millimeters of mercury, and that's considered normal, or it can stay the same. So when we're really thinking about blood pressure here, we're talking about systolic blood pressure. A drop in systolic blood pressure with an increased workload is a normal finding. C, that's not correct. That shouldn't happen. That indicates an abnormal response, and that person's not maintaining their cardiac output with the activity level. And that's not what we're looking for. And that's an indication to decrease the intensity or decrease the activity, depending upon or stop the activity, depending upon the patient's symptoms and signs and symptoms that you have with the patient. The size of the blood pressure cuff does not affect the BP reading. We had a couple people there. It absolutely does affect the BP reading. If it's either too small or too big, it can give like either artificially elevate or give a blood pressure that's too low. So it's really important that you have a blood pressure cuff that's the appropriate size. The appropriate size is that the bladder of the blood pressure cuff. So the inside, so when you have a blood pressure cuff, you have the cloth piece on the outside, but on the inside there's the bladder, and that's the part that inflates and deflates, and that should encompass about 60 to 80% of the patient's arm for an appropriate fit. So, and again, if it's not, you're increasing the amount of air you have with the blood pressure. And A is also incorrect. It actually, a drop in systolic blood pressure often indicates, with an increased workload, often indicates that there's left ventricular dysfunction or ischemia. So there's usually a connection there. It's not always, and we certainly can't diagnose left ventricular ischemia based on someone's blood pressure. However, it usually does indicate that there is something wrong, that they can't maintain their cardiac output. So the intensity of the activity is too high. All right, good work with those questions. I think we're pretty much at the top of the hour now, so that's a good place for us to stop. I want to wish everybody, I know some of you are taking the exam after the holidays, so best of luck to you, and good job to everyone else who's studying out several months here in order to prepare for the exam. So good luck to you all, and hopefully we'll see you back at another one of these in the future. Good night.